Okay, special topic, denervation. So let's talk about this. First case here, we've got a fluid-sensitive MR sequence. It's fat saturated. How do I know that it's fat saturated? Well, I like to look in the marrow cavity right here. See that? See how it's dark? That's how you know it's not. That's how you know it's fat saturated. Also, you could tell that it's um, the subcutaneous fat is also saturated out. Um, so what are we seeing here? We've got this is the right leg, this is the left, and we're going to see what's different here. These two muscles, which are the gastroc muscles, medial and lateral gastrocs, look like they have edema in them. They're edematous. They're relatively hyper intense compared to these other muscles on this fluid-sensitive sequence. So, edema in the muscles, what does that mean? What does that mean? Has he got a strain or something like that? Let's take a look at the T1 next to the, so same leg now, these are both the right leg, T1, and this is a stir. So again, not fat saturated. Notice the marrow cavity. Usually, if you're looking for a T1, it looks like this here. So a thing to think about anytime you see edema in muscles like this is denervation. Now, you may be thinking, hey, that's strange that the soleus is spared. I thought that they had similar innervation than the gastrocs. Well, it's not always a motor pathway. It's usually motor pathway, but it sometimes can even be a dermal, like the sensory distribution as well, which is sort of messing you up. But this is a case of acute denervation. So let's talk about acute denervation versus chronic denervation. So acute denervation is bright on stir. It's hyper intense. It looks like edema. Normal T1 and normal volume. And what do I mean by that? I mean it's not atrophied. So it looks like edema. Versus chronic, it's bright on T1. What do I mean by bright on T1? I mean that it looks like it's fatty infiltrated. Also, the volume is decreased. There's atrophy. The stir will have normalized. So, next case. All right, so this is a CT through the level of the mandible, and you're noticing that there's fatty infiltration of half of the tongue. So MR correlate here, T1, you can see the sub-Q fat, and notice this, again, fatty infiltration involving half of the tongue. So again, this is a denervation case. It's following that cranial nerve distribution, cranial nerve 12, the hypoglossal nerve, and it looks like fatty infiltration. So going back to this guy, the tongue thing, what do you think the classic history for that is? Like, what do you think? Who gets hypoglossal nerve denervation? You were going to guess. Who would be at risk for that? Basically, people who've had like head and neck surgery. Cranial nerve 12 passes through the submandibular triangle, and then it's a triangle under the posterior belly, the digastric muscle. So it's like it's curving around the neck. Like here's a gross anatomy picture. That's the hypoglossal nerve right there. So you can imagine that if you're digging around underneath of the mandible, that thing could be nicked. Another piece of trivia about that is, I remember this from step 1. If it's peripheral, it deviates towards the side of the injury. Like this would be the side. And if it's central, it deviates away from the side of the injury. Like if it was in his brain, it would be up here on the opposite side. Remember, because a lot of these cranial nerves cross over. All right, so let's get in. This is more high yield right here. So 2 MRI T1s of the shoulder, and I'm just going to put some green on here. Let's say that these two muscles are fatty infiltrated versus that muscle there, fatty infiltrated, sparing the one on the top. So the first thing you have to know when you're dealing with a question like this is, what the names of these muscles are. Not a lot of people, it depends on your background whether or not you've had any exposure to shoulder MRI or know this anatomy or not. So I'm going to give you a crash course real quick. So this is what I do for anatomy here when I'm doing the shoulder. First thing that I want to do is I want to find anterior. Okay, I want to find anterior. I want to find this thing right here. So what's that thing? That thing is this thing right there. That is your coracoid. And if you find your coracoid, then you know what anterior is. You can feel that thing on the front of your chest. Chromium's in the back, and then we're gonna talk these muscles around. Okay, so these guys and these guys. So sits is a mnemonic that a lot of people use. S-I-T-S. Supraspinatus, infraspinatus, teres minor. Teres major's down here. That's not one of the rotator cuff muscles. And subscap. So S-I-T-S in that order around. You can find the three that are on one side and the subscaps on the other, or find the coracoid and you know the subscaps anterior and the other three are posterior. Now, what do you think that is? This one down here. What do you think that is? So a better question may be, what is this thing up here? So if you may remember the biceps tendon, which is what this is, that's the biceps, that attaches at the 12 o'clock position on the labrum. The triceps, this guy, attaches at the 6 o'clock position. So that's the one that's coming up from the bottom there. So there's your bicep, long head. Where does the short head attach? Here on the coracoid. So maybe that, or that maybe, that's usually short head of the bicep and the coracobrachialis coming up here, and then sort of everything else is either deltoid or pec. All right, so let's scroll through it again. So you can peek down here, watch the line come through. So deltoid, 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 deltoid. All right, here comes a rotator cuff. And some people will say, let's use this picture, that this looks like hair. So if he's got a haircut that sort of looks like this, you know, like that kind of handsome devil right there. If it's just imagine it's sort of like it's hair. It's supposed to be all the way across. You know, if you can see, you know, you can, if there's a big cleft there down to the bone, that's a full thickness tear. So walking around, sits is the mnemonic, right? S-I-T-S, right? This is going to end up down there, or S-I-T-S. Biceps coming up, so seeing them around there. Biceps tendon coming in at that 12 o'clock position. And around. That box there is the rotator cuff interval. That's where your biceps tendon is, and the little gap between the supraspinatus and the subscapularis. Supposed to have some fat in there. Another important anatomical landmark right here. Quadrilateral space. We'll talk about that in a little bit. All right. So this is the picture right here. This is the one. This is the money shot. This is the money shot. This is the one you need to know, okay? S-I-T-S, anterior, subscapularis, okay, triceps coming up from the bottom, quadrilateral space, teres minor, rotator cuff interval, short, or long head of the biceps here, short head coming up there. All right, now back to our problem. So here's a schematic. We're looking at the back of the shoulder, the posterior aspect of the shoulder, cartooned, and there is a nerve that runs like this called the suprascapular nerve, and it goes through this area right here, which is the suprascapular notch, and then it passes through this here, which is the spinoglenoid notch. Now, why is that important? Well, let's say that you have a space-occupying lesion, a ganglion cyst or something like that, that is pushing on the suprascapular nerve at the suprascapular notch. Well, that is going to denervate both muscles, right? It's going to hit them both. What if instead we have a mass that is pushing on the nerve at the spinal glenoid notch. Well, then that's going to spare the supraspinatus and only affect the infraspinatus because the signal is coming, it's coming this way, it's coming this way, it's coming this way, it's coming this way. Make sense? All right, back to our problem. So if we have denervation here and here, that's going to be a lesion at the suprascapular notch. And if we just have denervation here only, that's going to be denervation at the spinal glenoid notch, sparing the supraspinatus, the one at the top. All right. What about that one right there? Let's review the anatomy real fast. S-I-T-S, supra, infra, teres minor, subscapularis, coracoid, anterior. So teres minor. What if the teres minor is atrophied? What nerve innervates the teres minor? So we said that these two get innervated by the suprascapular nerve. What about this guy? All right, so there's a space right here, and through that space, an important thing passes, and that important thing is the axillary nerve. So this is the so-called quadrilateral space, and a possible anatomical trivia question would be, what are the borders of this quadrilateral space? So there's this thing, triceps, there's this thing, teres major, that thing, teres minor, and then there's the humerus on this side. That's what this is. That's a humerus. All right. So back to our picture. Teres minor, teres major, triceps coming across, humerus. Got it? All right. So you see axillary nerve denervation, that's for the teres minor. You see that, you think quadrilateral space syndrome. All right, now, what about this situation? So, again, let's do the anatomy. Supra, infra, teres minor, subscapularis. So we said that this one and this one innervated by the suprascapular nerve. This one here is innervated by the axillary nerve. Those are different, right? So what is going on? How can they both be denervated? They're from different nerves. So there's this entity that anytime you see denervation in the shoulder that doesn't match a specific nerve distribution, you should think about Parsons-Turner syndrome. Not well understood. Just think about it maybe as like autoimmune, inflammatory, something, spectrum, lupus, whatever, some kind of unknown irritation of the brachial plexus higher up that is hitting those multiple, nerves that, it's involving different sensory distributions. It's not well understood. Neurologists like to study it. They don't understand it either. But it does have a name, and it's described in radiology literature, and that's when I would go for it. All right. So now we're looking at a foot. How do I know we're looking at a foot? Here is the base of the fifth. Here's a little bit of the calcaneus right here, and I'll tell you that there is a fatty atrophied muscle. So this is Baxter neuropathy. MSK guys love this fucking thing. It's for whatever reason, and it's fairly common. I feel like I've seen, a bunch of cases of this. It's not rare. So it's an atrophy of the little toe muscle, or if you want to sound smart, adductor digiti minimi. So this basically means the pinky toe. So the little guy, toe. And it's from and it's supposedly an injury to the inferior calcaneal nerve. your lateral plantar nerve, which is a branch of the tibial nerve. And remember, the tibial nerve is a branch of the sciatic nerve. All right, so last one here. So we've got a short axis cut through a foot of not just anyone's foot, but the foot of a 600-pound diabetic smoker who refuses to take his statins because he's afraid that they'll hurt his liver. So anytime you're doing an MR of the foot for osteomyelitis and a diabetic, you see this, and you see it so commonly that you probably don't even pay attention to it, that you've got edema in these intrinsic foot muscles and also some fatty infiltrations like acute and chronic denervation changes. And this is like diabetic neuropathy. These are the diabetic neuropathic changes that you see in the feet all the time. Like at least when I dictate these, just expected denervation, chronic denervation changes, just buried in the body somewhere because it's an expected finding in a diabetic foot, essentially. But could be shown on the test, and a good way to ask it would be, what is the patient's history? It's probably diabetes, right? So, but that's it. So those are the major ways to show denervation in the MSK, and also a little bit of neuro there with the tongue. Hypoglossal nerve, remember that. All right.